This fall, Nan is headed to Palm Springs, California. Set aside the backdrop of desert skies, we're creating a space for neonatal nurses to take the stage, sharing knowledge, amplifying voices, and driving change. Join us from September 9th through 12th, 2025, to learn from experts, engage in powerful discussions, and take action to drive meaningful change in neonatal care. Head to nan.org/conference to learn more. Hello and welcome to NANcast. I'm Jill, your host. Necrotizing Enterocolitis, or NEC, is a diagnosis that we all fear. NEC remains one of the most devastating gastrointestinal diseases affecting the preterm infant. Yet despite decades of research, defining, diagnosing, and preventing NEC is still a major challenge. How can we, as NICU nurses and APRNs, take an active role in identifying NEC earlier, improving prevention strategies, and ensuring our daily practices reflect the latest evidence? In this episode, we'll explore why NEC is often called a misnomer, how our evolving understanding of its pathophysiology, including the role of the intestinal microbiome, shapes treatment, and the impact of common NICU practices like antibiotic use and feeding choices. We'll also discuss some of the most exciting advancements in NEC prevention, including the role of probiotics, emerging biomarkers, and the potential for AI-driven predictive tools. Our guest today, Dr. Josef Neu, brings extensive expertise in neonatal research in developmental gastroenterology and neonatal biochemical nutrition to help us unpack these critical issues. Dr. Josef Neu is internationally recognized for his research in developmental gastroenterology and nutrition, and most recently has focused on multiomics and artificial intelligence for predictive analytics for intestinal injuries, ROP, and precision nutrition. By the end of this episode, we'll answer the key question: how can redefining NEC and improving early detection transform neonatal care and outcomes for our most vulnerable patients? Let's get right into it. Thank you, Joe, for joining us today. Your presentation at the conference mentions NEC as a misnomer. Could you explain why you believe that term is misleading?
Sure. Well, historically, we've been calling this set of problems necrotizing enterocolitis. And if you go back in history, it's very interesting that when neonatology first started, we were seeing babies who developed necrosis of the intestine, and it was found to be a very terrible problem. Many of these babies died, and we really didn't have a good reason for this problem occurring and why these babies were dying. But then in the mid to late 1970s, Dr. Martin Bell from Kansas developed these criteria or staging criteria called Bell's Stage 1, 2, and 3 necrotizing enterocolitis. Well, it's interesting that we've been calling so many things necrotizing enterocolitis where there's no necrosis at all. So certainly Bell's Stage 1 and 2 necrotizing enterocolitis represent entities where there is no necrosis of the intestine. And especially with Stage 1, now in 2024, I think that that's an anachronism. We see babies who have slightly distended abdomens. We see babies who are having apnea and bradycardia, who are vomiting, just showing some signs of intestinal instability. But I would venture to guess that probably all babies less than 750 grams will show this. And if we say that these babies have Stage 1 necrotizing enterocolitis, the vast majority have absolutely no necrosis of the intestine. And probably the same holds true for many of the babies that we have coined Stage 2 as well. These are radiographic signs in general that go along with some clinical symptoms. And many of these radiographic signs we are beginning to find are not really pathologic, but these are mistakes made by the radiologist. Well, actually, it might be a little bit too dramatic to call them mistakes, but overreadings made by the radiologist, where the radiologist will express some suspicion. And then when we see the radiology report expressing the suspicion, we will become very concerned that perhaps this baby does have something pathological going on, but many of these babies don't have anything pathological going on, and we end up over-treating them. We put them 7 days NPO. We give them antibiotics for 7 days. And really, this is actually causing more damage than good. So I think that we have to begin to consider going back to the beginnings of neonatology and think about how we can better term some of these intestinal problems that we are calling NEC.
That's so true. If you see pneumatosis, you have different providers all around the computer looking at the film, trying to see, is that where they think there's pneumatosis? And then this leads to a whole NEC treatment. And I agree. We do see that a lot. Do you think that because we have this lack of a true definition or understanding, and this is what's leading to us not having much progress in treating NEC and defining?
Absolutely, Jill. Absolutely. I think that we have been trying to, at least in the last few years, trying to define NEC. And if you look at one of the papers by Dr. Ravi Patel that was published a couple of years ago, there were 8 definitions of NEC that were proposed. And there's just something, if you have 8 different definitions, to me that means we really don't have a definition. So I'm beginning to think more and more that this is like a gumball machine, where you have gumballs that are different colors and different flavors. And what we need to do is be able to separate out these different gumballs and these different flavors. And then each one of them will have a different kind of a pathophysiology, sort of like diabetes. We have type 1 diabetes, we have gestational diabetes, we have adult onset diabetes. We call them all diabetes, but their pathophysiology, their preventative strategies, their treatment are so different from one another. And I think this is where we need to go with what we are calling necrotizing enterocolitis. Well, let me talk a little bit more about a little bit of the history, and I think that that this is really important. This aspect that I want to talk about, and that is studies in animals for looking at necrotizing enterocolitis, and we have numerous studies that have been done in animals, and I think that they may have helped us a little bit with better understanding of intestinal problems, but whether they actually have contributed to our preventative strategies for what we are calling necrotizing enterocolitis is highly questionable. So one of the main animal models was a model developed at Columbia University in the late 1970s by Drs. Pitt and Barlow. And this involved taking baby animals and putting them under hypoxic ischemic conditions for periods of time, subjecting them to cold stress, giving them a food that is very different than what they would be getting in utero. And these animals did develop necrosis of the intestine, or at least intestinal damage. But the pathophysiology is just not the same as what we are seeing in our premature babies, and so I think that some of these studies have also led us astray. We have studies in piglets, which was thought to be a better animal model for the human, but when you really think about the type of immunoglobulins that these piglets are getting from their mothers. If you don't give an immunoglobulin to these piglets shortly after birth, and if you feed them a formula, they will develop a problem with their intestine. That is not the case for our premature babies. So it's just a very different type of mammal, the human versus the piglet.
How has the understanding of NEC's pathophysiology evolved over the years, and what role does the intestinal microbiome play? Because I know we were talking about the animal studies, but how does that translate into our babies that we care for?
Sure. So I think that one of the first things we have to remember is that we have babies who are very preterm, and these babies are highly prone to gut injury for various reasons. Their intestinal mucosa is just not yet very well developed. They don't have the types of goblet cells that produce a lot of mucus, which is protective. They don't have the types of Paneth cells that are protective for the mitotic regions of the gut. And they're highly prone to also developing leaky gastrointestinal tracts, where the spaces between the epithelial cells begin to open and allow for passage of microbes or microbial components, and also can this can lead to an inflammatory response, because you have the inflammatory cells right below the intestinal mucosal epithelial surface. So that's, I think, one of the first things to remember in terms of the pathophysiology, and that's a perfect setup for leading to problems. Now, when it comes to the microbes in the gastrointestinal tract, over the past decade and a half, we've had the opportunity and the technologies now to not just do culture-based work. Cultures if we use culture-based technologies, it's really difficult to be able to find all of the different microbes in a particular niche like the gastrointestinal tract. Now with these newly developed microbiome technologies, which are sequencing technologies, we're able to find and identify the microbial taxa much more readily than using culture-based technologies. So we're able to find out what bacteria are there. We also have technologies that give us some idea of what they are able to what these bacteria are able to do, what their capabilities are. So I think that with these developments over the last couple of years, we've been able to collect samples from babies, and numerous neonatal intensive care units have been doing this, developing biobanks where they collect poop samples and put them into freezers and save them there for long periods of time. And then once you have enough babies that are controls versus babies who have developed NEC, you can actually do these microbiome technologies. And we've been able to do this, and we found that the babies who have developed this diagnosis seem to differ in terms of the types of microbes that we find in the gastrointestinal tract when we compare them to controls. So one of the first kinds of microbes that we see that differ are a phylum of microbes called the proteobacteria. And these proteobacteria have large amounts of what is called lipopolysaccharide in their cell wall, or LPS. And LPS stimulates certain receptors in the epithelial cells and macrophages of the intestine. And these receptors then respond by inducing an inflammatory response. So we see more of these bad guys, these gram-negative, the proteobacteria, develop in the babies who are more prone or who end up developing NEC. we see a decrease in another phylum of bacteria called the firmicutes. And these are the good guys. So the bad guys are increasing, the firmicutes, the good guys, are decreasing. And what the firmicutes do is that they produce certain metabolites, like short-chain fatty acids, that help provide protection to the GI tract. One of the protective measures is keeping the intestinal tight junctions, the epithelial tight junctions together so that they are not as leaky. So I think that that's just one of the other factors that can be protective with the firmicutes. So the bad guys go up, the good guys go down, and that seems to set up the gut for these intestinal damage.
So in your presentation, you did put a meme up that says, "We have met the enemy and he is us." So are there, what role do we have as NICU nurses and NICU providers that can contribute to affecting the microbiome of the infant that could set this baby up for risk of NEC?
Okay, so let me just begin. By saying that, what I just talked about in terms of the microbiome, that's an association, okay? And association does not mean that it is a cause. There's probably, it's kind of hypothesis generating, and I think that when we talk about causes, we only have hypotheses right now. We don't have a definite causality, and especially the fact that we don't have a good definition, a good endpoint, that makes things really, really tough. But there are things that we do in the neonatal ICU that change the microbiome. And one of the things that we do so often is we give antibiotics pretty much willy-nilly to these babies. And I think that over the last decade or so, we've started to improve. We've had quality improvement measures in different ICUs. I think we've begun to recognize that these antibiotics, are not benign. I remember hearing so often, "Oh, 2 days of antibiotics, this is not going to harm anybody," But studies have been done looking at these microbial profiles with only 2 days of antibiotics, and you can see at 4 weeks and 8 weeks and down the road that there are differences in the microbes after giving only 2 days of antibiotics. And there's some observational studies that have shown that the longer we give antibiotics, the greater the risk of the development of necrotizing enterocolitis. And again, that is not a proven causality, that's an association. It may just simply be that we're more worried about those babies and we give more antibiotics because we're more worried because they're sicker babies to begin with. And because they're sicker babies to begin with, that's why they develop NEC. But I think it's still an interesting an association, and we need to do more work in that area to be able to understand that better. Certainly, giving these antibiotics willy-nilly also cause antibiotic resistance genes to develop, and I think that that's another problem that we have to be concerned about. Another aspect is if we don't put food into the gastrointestinal tract of these babies early on. And this is something that I remember historically. There were times when we would not feed babies for a week, 2 weeks, and even longer because we were afraid that any kind of feeding, putting any kind of food in the gastrointestinal tract, is going to cause these babies to develop NEC. Well, that's problematic because not only do we thwart the development or delay the development of growth of the intestine, what we also do is change the microbial environment. And one of the things we see in those babies who are not fed is that we see a preponderance of the bad guys. the proteobacteria in the gut in comparison to the good guys. And so that's another factor that we have to be concerned about. Giving H2 blockers, which blocks acid, and this is something that we used to do so commonly, is give these H2 blockers because we thought that the apneas were caused by reflux.
Yep.
And I still hear this a lot in our own neonatal ICU, and I'm sure that others are hearing that all over the place. But the H2 blockers change the acid environment, decrease the acid output in babies who already have very low acid output. And that allows for certain types of microbes to get into the gastrointestinal tract, and that can cause potential harm. And studies have been done showing that H2 blockers are associated with a greater propensity for the development of late onset sepsis and necrotizing enterocolitis.
So knowing all of the associations that occur with NEC, what roles can a provider or a NICU nurse play in preventing or exacerbating NEC in your view?
Well, I think one of the first factors is, number one, feeding babies early. And what we feed babies seems to be important. And one of the things I really try to promote, and I think that we all try to do this, is to get the moms to provide their own milk for these babies. And colostrum is something that contains numerous bioactive factors. And baby's own mother's milk is personalized for these babies, and the skin-to-skin care really helps in the personalization, and where if a baby is colonized with a certain type of microbe, that baby's own immune system may not be able to handle that microbe, but with skin-to-skin care, close contact with the mom's immune system will be exposed to those nasty microbes, and her immune system will respond. And then that's something called the enteromammary system. And with her immune system responding, certain types of immune cells and also immunoglobulins that are specific for that microbe will be developed in her breast milk and be passed on to the baby. So I think that the skin-to-skin and the use of baby's own mother's milk is something that can be very highly protective for the baby's GI tract. So I think that the fresher the milk, the better. I think that freezing has some negative effects, but not terribly negative effects. But the fresher it is, it just makes more sense that using the fresher milk would be better for the baby. The question of donor milk is one that I think we need to take a step back and begin to really think about what kind of benefit we're providing with donor milk. And the more I think about whether donor milk is truly effective in prevention of gut injury, the more skeptical I get. And there's many reasons for that, and one of the first reasons has to do with the pasteurization process. So the pasteurization process involves half an hour of 62.5 degrees centigrade, and donor milk is not the same as baby's own mother's milk. It's very, very different. It comes from mom who are usually breastfeeding their own babies, and what is left over from the moms breastfeeding their own babies. It's usually not very early in the process of breastfeeding. In other words, in the first couple of weeks, where you see transitional milk that has more protective factors. Um, if you look at the composition, the macronutrient composition, especially the protein, it's very low. And so if we don't provide the correct kind of additives to the donor milk, we could actually be causing harm to these babies. So I'm very concerned about, number one, the macronutrient composition in donor milk and how we handle that. I know that there are certain apparatuses used to measure protein, and I think there are neonatal intensive care units that are using these apparatuses, but it takes measurement of these of the milk, and then you have to add the protein, and usually you base that on growth curves. But if you're seeing faltering on a growth curve, damage has already been done. And so I'm very concerned about, I think, the reliance on donor milk over baby's own mother's milk. And there have been some neonatal intensive care units that have shown a decrease in the use of the baby's own mother's milk when the donor milk is available, because we get a little bit lax thinking that it's the same thing. And then there's all the bioactive components in baby's own mother's milk versus the donor milk. So the bioactive components, some of these bioactive components that are destroyed include some enzymes. One of the enzymes is lipase. Another one is alkaline phosphatase. Alkaline phosphatase actually has the ability to inactivate some of those bad guys that I was talking about before, the proteobacteria that have a lot of lipopolysaccharide in their cell wall. But we completely destroy that enzyme by the pasteurization process. So I think that there are some studies suggesting that donor milk is potentially beneficial in terms of necrotizing enterocolitis. But I think that a lot of those studies are also older studies, and we have to be very careful in relying on the donor milk. There are some studies that have been done by Debbie O'Connor and colleagues in Toronto that have actually shown that you see more neurodevelopmental problems with donor milk compared to formula. So, I think we need to, I'm not saying that one is better than the other, but to have a reevaluation of this whole field, I think is in order.
I know in the institution where I work, we try to change the culture and tell parents that mother's milk is more of a medicine, to have them look at it in that perspective, instead of, like you said, sometimes we get lax with the availability of donor milk, but to really drive the importance of mother's own milk is a medicine for your baby. And I think when you present it like that, it changes some of the thinking of the parents and really encourages them to continue pumping, continue with skin to skin, and help that milk production. And it really gets everybody on board to support those parents with providing.
Yeah, I think that that's a really, really good point. And, we are giving so many medications and doing all this intensive care for the baby. And this is something that the mom or the family can actually play a real role in their baby's care.
And then with your thoughts on fortification, a lot of institutions have feeding protocols that they follow as far as when to start fortification. And I know when babies have a neck scare, so to speak, we want to say, oh, well, we just started fortifying the baby. And so what are your thoughts on fortification?
Yeah, that's a really, really interesting question. And, I think that some of the evidence that we have suggests that early fortification is a good thing, okay? Once you're at somewhere around 50-60% of the enteral intake, it would make sense to begin to fortify from a macronutrient and calcium and phosphorus perspective. So I think that that would be very reasonable in most of our babies. But remember, one size does not fit all. And so one of the things that if we have a baby who's had some previous problems, who's had significant feeding intolerance, I may take a different approach for a baby like that, and that is to get that baby up to full enteral feeding with just the baby's own mother's milk before I start adding the fortifier. Fortifiers in the bigger babies, when you get to 31, 32 weeks gestation, if they are taking their feedings really well, I question the need for fortifiers in those bigger babies. But I think in your little 26, 25 weeker, it's pretty obvious that those babies still need to have fortifiers.
I thank you for clarifying that, because I know that that's always a controversial topic or a hot topic amongst NICU nurses with fortification.
Yeah, and again, I think that right now we have this what is called evidence-based medicine, which is great, okay? But the evidence-based medicine, and if we have evidence that fortifiers for the general population is good to start at around 50-60% of enteral feedings, we should take that seriously for a large number of our babies. But that should not be a law. Okay, we can still use some clinical judgment for some of these babies, because if we don't use that clinical judgment, we can hurt them.
Sometimes I think we try to hold these protocols to, as the end all be all, and we sort of lack that clinical judgment piece in there.
Yeah.
The talk of use of probiotics, can you elaborate on the evidence regarding probiotics as a preventative measure for NEC? I know that that's been a hot topic.
Yeah, it's a very hot topic. And let me just start with the transition from mother's milk, okay? And one of the things that we need to remember that mother's milk contains microbes, okay? I know prior to 10 or so years ago, one of the things we used to do if we were at all concerned about the mother's milk having some kind of infection, if the mom had mastitis or whatever, we would culture it, and if we saw bugs, we would not breastfeed, we would not use that milk for the baby. But now, over the past 10 years, we're recognizing that mom's milk contains a myriad of microbes. And for each mom, it seems like there's a different set of microbes, that it's almost a personalized set of microbes for each mom. And when these babies are getting full breast milk feedings, they're actually getting about 10 to the 6th microbes per milliliter of material. Okay, so it's actually a goodly number of microbes that these babies are getting from their mother's milk, which seems to be personalized for them. Okay, so when we transition to the probiotics, I think that we need to remember that if we're going to use probiotics or thinking about using probiotics, there are already probiotics in baby's own mother's milk. Not so much in the pasteurized, because the pasteurization process will kill those microbes, okay? But the fresh milk has lots of microbes. Okay, now microbes are actually potentially beneficial for the GI tract, and we have a lot of microbes, a lot of different types of microbes in the GI tract. And one of the beauties of those microbes is that they train the immune system. They actually help the development of the immune system. And those the microbes also are able to provide certain metabolites that get into the bloodstream and get into the brain, and they can help in brain development, something called the gut-brain axis. So having microbes in our GI tract is very, very important. Now, over the past couple of decades, it's been thought that maybe if we introduced microbes into the GI tract in the form of probiotics, live microbial agents that we think might be beneficial for the host, then that we may actually be helping prevent gastrointestinal problems such as NEC, or maybe even promoting feeding tolerance in these babies. So I still recall back in 2010 there was a meta-analysis done and published in the journal Pediatrics, and that meta-analysis involved 11 different neonatal intensive care units and 10 different probiotic preparations. Okay, this is a meta-analysis of 10 different probiotic preparations, and it suggested that in this meta-analysis that there was a real benefit to using probiotics. And then there was a commentary that came out along with that that said it is now unethical for neonatal intensive care units not to use probiotics. But the question arises, which one of those probiotics should we be using?
Exactly. If they tested 11.
Yeah. So which of those probiotics should we be using? And was there ever a good prospective randomized trial that was done to really look at which one of these probiotics as a preventative for necrotizing enterocolitis that was adequately powered for the prevention of necrotizing enterocolitis? These studies and these meta-analyses never were powered for the prevention of necrotizing enterocolitis, and they almost always included several different strains or different types of microbes. So I think that that led to certain questions, and the regulatory agencies were, I think, very correct in being concerned, because one of the things that you can do with using a probiotic as a food is that the commercialization and the production can be very trashy. And we have to be very careful in these highly susceptible babies in the type of production measures that are being taken. And so I remember several years ago there was an incident at one of the neonatal intensive care units using ABC Dophilus. This is a type of probiotic preparation that was commonly used, and it was found to be contaminated, and it caused some real problems in babies. More recently, bifidobacteria was found to cause sepsis in some premature babies. Overall, though, a lot of probiotics have been used without significant adverse effects, but we don't go around looking for adverse effects in these babies either. So, it could be that some of the babies were having adverse effects, but we just didn't recognize it. So I think that at this juncture, we do. I am. This is a disclosure. I am involved in a study that is just in the process of being fully analyzed. It has not yet been subjected to a peer review process, and I think that we'll be learning more about that particular probiotic in the near future once it gets peer reviewed, and we'll see what. I don't want to talk about it in a lot of detail at this juncture, but I think that there may be a role for probiotics, and we'll see what happens in the future with this particular agent. That it involved a study of 2,200 babies in nearly 100 neonatal ICUs in 10 different countries. And so I think that it'll be interesting to see what happens after peer review.
We'll all anxiously be waiting for that article to come out. And then hopefully we can maybe learn how we can use probiotics in our NICU. We already talked about strategies for NEC prevention, but in a different light as far as predictive tools and machine learning, which you did touch on in your presentation on multiomics. How can that aid in diagnosing NEC and differentiating it from other conditions? Because we did talk about the broad definition of NEC.
Well, let me start with just saying that what we are calling NEC is, and I mentioned this before, is this broad category of illnesses, sort of like the gumball machine or a bunch of different kinds of fruits and vegetables in one basket. And this is highly problematic because if we are not very nuanced, we're not going to make progress. I can assure you that we're just not going to make very much progress in this area. And so we have recognized over the last decade or so that we have babies with congenital heart disease that develop necrosis of the intestine, okay? Hypoplastic left ventricle, interrupted aortic arch. That's a really different pathophysiology from what we are seeing with many of our premature babies. And we're calling that NEC, okay? But it's a different pathophysiology. We have babies with spontaneous intestinal perforations, okay? These tend to happen very early after birth. And they're happening in the most premature babies, but surgeons will place a drain, and we never know whether there's necrosis of that bowel or not, unless the surgeons will actually go in after, maybe finding that things are just not working with the drain very well, and then they find necrosis maybe at a later point in time. But many babies will have a drain, and they will end up healing, and but it's still a different pathophysiology than what we see later on in many of these babies in terms of what we're calling necrotizing enterocolitis. We have some babies that develop these bloody stools and don't have very sick-looking abdomens. Many don't have pneumatosis, and if you change their feeding to a highly elemental feeding, then you can begin to say this baby has something different. This is more of a protein intolerance, or FPIES. And we have some babies with just significant motility problems that just don't pass their food through very rapidly. They can get some abdominal distension, and we take x-rays of those babies, and we'll call pneumatosis, it's pupatosis, and we'll call it pneumatosis, just because they're not passing their stools very readily. So this is highly problematic because there's so many different things that we are calling necrotizing enterocolitis. And we have to begin to develop a more nuanced approach. And one way that we can do this is by the use of different forms of artificial intelligence. We have used something called supervised machine learning to be able to help us find features that can help us separate babies who are more likely to develop spontaneous intestinal perforation versus actual necrosis of the intestine, okay? So that's something called supervised machine learning, where you know what the baby actually has, and then you can look back at the chart and you can put in a whole bunch of different features and see what features differentiates those babies. And then you can say, okay, this baby is at much more risk of having actual necrosis of the bowel than just a spontaneous intestinal perforation. That's called supervised machine learning. The other approach is unsupervised machine learning, okay? And that's looking at your gumball machine or your basket of fruit and separating out what is in that basket. So we have this big basket of all kinds of intestinal injuries, and one can use unsupervised machine learning, different algorithms that look at different features and put these different features together in certain kinds of, which different features categorize more closely with each other. And so you'll find a banana in this, because it's elongated rather than round, it's yellow rather than red, okay? Those are features, and it will separate the banana from the rest of the fruit, okay? And that kind of machine learning is called unsupervised machine learning and can help us find different clusters of intestinal injury. And we have done that in one paper, just in one neonatal intensive care unit. And what we need to do is see if this is something that can be done in a more generalized way in many different neonatal intensive care units. Now, I've talked to the Neonatal Network, and their data is not, in the US, their data is not what we call granular enough. They don't have enough of these features available to be able to do the clustering. But then I've also talked to the Canadian Neonatal Network and the Korean Neonatal Network, and both have started to do some of this. I haven't seen the results yet, but we do want to look at thousands of patients to be able to see if we can find different nuanced categories of intestinal injury that we can then start looking at in a more sophisticated way. So in order to look at it in a more sophisticated way, one of the things we can do is using omics, okay? Now remember, we used the microbiome before to be able to evaluate the different kinds of microbes. Well, I mentioned that provides an association. But if we can put together different omics, like the genome, the microbiome, what these microbes are producing, how the host responds with an immune response, what kind of metabolites are present, and how those metabolites are affecting the host. I think that will help us in each one of these clusters, in the banana, in the strawberry, in the orange, tell us what is going on in those particular different clusters that is pathophysiological. And then we look at which one of those clusters causes the most damage or is the sickest. And then we really dig in and compare what is going on in that cluster to the ones that are not as ill. And then we can develop pathophysiology within those clusters and find biomarkers that I think we can begin to use really early on that says, okay, this baby is at really high risk to be in this particular cluster, this high-risk cluster, and we got to pay particular attention to making sure that this particular baby gets, X, Y, and Z early on to prevent this.
That's amazing. That the fact that we can utilize all this technology, I think that AI is such a important component we're going to see more and more in our practice in the NICU.
Yeah, it's available right now, and it's not that we would be doing all of these sophisticated studies on each one of the babies, but what the AI and the multiomics will help us do is find those babies who are truly at highest risk and find out what we might be able to do early on to prevent this from occurring in a very nuanced way.
And that's our goal, right? And yes. I think after talking today, we have so much more to learn. And we have we haven't made much progress. And I think we all know that we can't believe the term of NEC that we use today. And we kind of have to get rid of that term and look at it in a whole different lens.
Yes, I totally agree. And, again, as we started, the term necrotizing enterocolitis is a misnomer. And sort of the concept here, or the dream, is to go back to the 1960s, 1970s and make believe that we never even invented the term necrotizing enterocolitis for these babies, and now apply all these technologies that we have available and find these more nuanced clusters and find totally different names for these different problems, so we can label them correctly and more accurately.
Thank you, Joe, for joining us today. I think we have all been very enlightened, and it's really going to allow us to look at NEC in a whole different way. So thank you for joining us today. Make sure you never miss an episode of NANcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.